and it there is a high yield topic discussion. That would be like a separate notebook for you, and it will be the one day in a week. And there will be some mock exams again, that will be after that, again the mock exams about from these high yield topics from the past year paper, from the test center question. And before your exam preparation, again there would be the some mock test would be there. The mock test like around 150 questions you will get on the like according to recent examinations, according to the recent exam preparations, exam schedules. So all will be done like that. And everything that we will discuss will be concept wise explanation of each. There will be the concept wise explanation of each topic. Along with that, you I will take around one-on-one sessions, like if you will finish the classes after that, and I will take your guidance session also, in which you can discuss your query, you can discuss your any problem related to the revisions, anything related to that. I can call you on the WhatsApp, or I can call you on the, you can meet me on the Google Meet. So this will be the different guidance sessions in which I will guide you throughout your journey, and we will discuss everything in the details, like what the strategies you should follow, and what you should not follow. This will be like one-on-one sessions. Nobody will be in the class, only you and me would be there, and you will discuss, because sometimes I see the students that feeling the little bit difficulty while talking with the other peoples in the class. So that's why I have arranged these sessions as the one-on-one guidance session. So whatever your query would be there about the revisions, about the strategy, about you are not able to fulfill anything, any related to any problem would be there, that will be discussed in this guidance sessions. And so this is our little bit that I had tried to provide you the theme for the classes. So this would be the this discussion would be there. I hope this is clear. If you have any doubt, you can ask me, or you can message me on the chat box. And yeah, I know, for some students there is some problems related to the timing also. So the timing of the classes, that would be around in the evening of the Ukraine timings, evening of Ukraine time. Maybe like it can be the starting from the 6 to 6 or 8. Maybe like between the, it will start from the between the 6 p.m. to the 8 p.m. This is the starting time, or I will write it like this. The starting time would be 6 to 8 p.m. and the ending time would be around like after 3 hours, after 2 to 3 hours basically. It depends on like how we make it the classes. So like we have to cover the syllabus accordingly, and according to that we will be having the 2 to 3 classes. And other doubts that I got, that you are doing the internships, and if I'm doing the internships, I'm doing the training in the here in the medical college, will you get the times? Because like I have also seen that there is a many teachers are there who took the money, who took the fees, and after that they don't involve in the classes. So this is my responsibility, this is my promise to all of you. Whatever the situations would be there, because this my internship is training is not so much hectic. So whatever the situations would be there, I will be there for you, whether it's anything would be there, because you can ask from my previous students who took the classes from me. So I would be more than you, that's I can promise. Rather you are the mature students, so you can understand it easily. So whatever I will give my 200%. So this is what I have need from you, that you have to give your around 200%. Like if I say giving some homework, it doesn't mean that you are doing okay, we'll do it tomorrow. At least like try to do in the time, that's you have to done. Whatever the topics we will discuss, like for example we have topic the rheumatology today, you have to finish it just after the class, or read it just after the class. After that take some break and then revise it. That you have to do. After that you have to remember the same things on the next day. This is a very little things you have to do, other just enjoy the life. Okay, this is your final year, and I understand that you will be feeling that you have to roaming outside. You have to, if you are in the Ukraine, you have to survey all the Ukraines. You have to go to Lviv, Kiev, Kharkiv, whatever the the beautiful city. You have to roam out there or here. That's okay. It's natural. It's go out. You have the time, but believe me, this sixth year is very crucial time for you. This sixth year is very crucial time for you. I hope every one of you see there is a one web series is there that I will say to watch you before that. Whenever you will be free, don't watch it today. There is a one breathless, or in the Spanish it is the respira something. Okay, that you have to see. In this you will see, like whenever you will be the in the training period, you will feel that it kind of the it will give you the little motivations, and it will boost you up, and this is what you have needed in this sixth year. This sixth year is very crucial for you. Please try to do your best in this sixth year, because after that the life will be simplified, changed. You will not able to get this enough time that you are getting it now. You will be not able to study this much as you will study in this sixth year. Okay, so we will keep discussing everything in the details, and we will keep motivating each others, because your motivation is also helpful for me. So we will keep doing the our best, and with so let's try our best, and with that best, let's start our subject about the rheumatology. Do you have question about anything? So you can ask me about. Then we will start. Please share the strategy for the November exam preparation. Huda, I will message you. Okay? I understand you. I know you. Okay? So I will message you accordingly. Any other question you want to ask, or any other query? You can just thumbs up or thumbs down like this. Will the classes will not be daily. Classes will be around 3 to 5 days per week. Okay? The classes will be 3 to 5 days per week would be there. There will be no daily classes, but I will give you the daily schedule also. Okay? The for preparations, I will give you the daily schedule, so that you will be not be distracted on this little bit days. And most probably this week we would be having classes in the weekdays, and in between we will be having the classes in the most probably we will be having classes in the weekends, and according to your timing also. And those who have the timings difference or the timing problems, don't worry about that. Just talk to me, we will handle that. Okay, I will let you know how to do that everything. So don't just before that message me for that. Okay, don't worry about the timing. I had the student from the UK also last time, so we have managed everything. Any other question, or shall we start? Okay, I can open your mic. Okay, wait a second. Okay, now you can switch on your microphone, and you can, if you have any query. Okay, no question. Okay, so let's start then. Okay, please try to make the notes, write everything on the notes, and make a notes about everything. Whatever we will discuss it today, like about the rheumatology we will discuss. So make a separate notebook, and keep writing along with me, and also understand whatever I will teach you. So the first that we are going to discuss, that is about the cross to rheumatology. So there are some rheumatology question that I had pick up, and in between there is some question about the joint disorders also that we will also discuss. So let's read the first question. The first question is saying a 30-year-old female with a rheumatoid arthritis, okay, that is rheumatoid arthritis for 5 years duration, complained of the pain in the first 3 fingers of her right hand over the past 6 months. The pain seems especially severe at the night, often awakening him from the sleep, the most likely causes. See, the pain that is like there is history of the rheumatoid arthritis, means there is involvement of the joints would be there, and there will be the pain sensation are there. That means this having some tingling sensation, the pain sensations, the paresthesia, the numbness would be there. They all, and the patient will be having the say that the history of the pain at the night. That means that the severe pain would be there. So this tells us about that is the carpal tunnel syndromes. So let's study about this. What is the carpal tunnel syndrome? So our first topic is about that the carpal tunnel syndrome. Okay, before the carpal tunnel syndromes, we have discussed about the one nerve is there, that is known as the median nerve. That is known as the median nerve is there. When we talk about the median nerve, remember the median nerve is what? That is the mixed nerve. The median nerve is the mixed nerve. What does it mean by mixed nerve? Mixed nerve means that it is having the motor supply and also having the sensory supply. Some nerves are the pure sensory nerve, some nerves are the pure sensory nerve. Like that, the median nerve is the mixed nerve. They having the motor supply and they would be having the sensory supply. They supply motor supply to the forearm and they have the motor supply to the hand regions. The forearm we would be having the anterior compartment muscles. The forearm we would be having the anterior compartment muscles which will get the motor supply from the median nerve. And we have the, in the hands we would be having the thenar muscles. In the hand we would be having the thenar muscles which will get the motor supply from the median nerve. Thenar muscles, like we have the flexor pollicis brevis, we have the abductor pollicis brevis, adductor pollicis brevis, opponens pollicis brevis. So these all are like the flexor pollicis brevis. You can write it full because just remember the thenar muscles. I am telling you the name. There is a flexor pollicis brevis, abductor pollicis brevis, adductor pollicis brevis, and that is what opponens pollicis brevis. Okay, these are the some muscles of the thenar. Then we have the sensory supply of the median nerve. What are the sensory supply? Sensory supply, when we say this is the supply, the lateral 3.5. The lateral 3.5 where on palmar side. On the palmar side. What is the palmar side? See, this is what we have in the palmar side. Like if I say this is my the palmar side. So if I will say the lateral 3.5, this finger and this finger and little half. So this little 3/2 of the finger is supplied by the median nerves. This is supplied by the median nerve. Then we would be having the next one, that is only tips on the dorsal side. Only tips where on dorsal side. So the dorsal side we would be having just these, the tips would be there, that is supplied by the median nerve. These sensory innervations, remember it going through the at flexor retinaculum. This sensory innervation, it's occur at flexor retinaculum. Flexor retinaculum. Okay. These sensory innervation, like we will be having the median nerve. So it at flexor retinaculum, it having the two branches are there. One we would be having, that is the deep branch. Another we would be having, that is the sensory branch. Another we would be having, that is the superficial branch. We would be having the superficial branch. Okay. The deep branch we would be having the motor supply and we would be having the sensory supply. When we talk about the motor supply, so motor supply we have discussed that these will be the some muscles would be there. What muscles? We have the thenar muscles would be there. We are having the thenar muscles would be there. and the sensory supply would be, that is the lateral 3/2 of the finger. Okay, then fingertips, and here we have the superficial branch that will supply the, that you have the sensory supply only. They have the sensory supply only, and that will supply the palmar area. That will supply the palmar area. Then what is here? Our topics came start. See, what is the carpal tunnel? Carpal tunnel, of course, it is the tunnel, or it is the gap, or it is the, like some cave would be there, where it is the space that is present deep to flexor retinaculum. It is structure. It is the space that is deep to flexor retinaculum. Deep to flexor retinaculum. What happened? We call this carpal tunnel syndrome. If there is some compression, if there is a compression of the deep branch, if there is a compression of the deep branch of median nerve, the deep branch of median nerve. Now see, the median nerve, this is passing through this carpal tunnel. This deep branch is passing through this carpal tunnel, and when there will be the compression of this deep branch of the median nerve, this is known as the carpal tunnel syndrome. This is known as the carpal tunnel syndrome. Okay, this is known as the carpal tunnel syndrome. So how the question will come? In the question they will give you that in the carpal tunnel syndrome, which branch would be affected, or which branch of which nerve would be affected. Firstly, they will ask you which nerve would be affected, so that is the median nerve would be affected. Then they can ask you which branch of the median nerve would be affected, then the deep branch would be affected, and the superficial branches, they have no effect in carpal tunnel syndrome because that is present superficially. So that's why they don't have any effect on the superficial branch of the median nerve. Okay, so you can say that if there is a no effect on superficial branch, no effect on the superficial branch. So if the no effect on the superficial branch, what will happen? There will be the palmar sensation would be intact. Palmar sensation would be intact. The palmar sensation would be intact. Now see, if with the compression of the deep branch of the median nerve, so what will happen? There will be the motor देखो, deep branch is supplying, having the motor supply, so there is the thenar muscle, sensory supply, lateral 3/2 of the fingertips. Let's see. So if the deep branch would be compresses, the motor supply will be gone. So there would be the motor atrophy. There would be the motor atrophy of thenar muscles, and we call this condition as the thenar eminence. This is known as the thenar eminence or thenar wasting, or thenar wasting would be there. Means thenar muscles will be decrease in the size. So there will be a decrease in the size, that will be the motor atrophy of the thenar muscles. Along with that, you will see there is some sensory sensation would be low. So sensory supply, like lateral 3/2 of the fingertip. So if fingertips are low, so means there is some sensory supply would be lost. So you will see the paraesthesia. What you will see? The paraesthesia, the tingling and numbness. There will be the tingling and numbness of what? Lateral 3/2 of the fingertips. Just on the fingertips, you will see some tingling and the numbness. What is the meaning of the paraesthesia? Can you even tell me? Again, this is the abnormal sensation. So what it means? Like the some tingling would be there. That is means paraesthesia. Like the somebody have the pins or needleless. So this is what, that is the paraesthesia. That is the tingling or the numbness. That is meaning the paraesthesia. Okay. You will see like the pin prick sensation. Like somebody have some prick the pin. So the pin prick sensation would be there. Pin prick sensation would be there. Along with that, you will see the symptoms will appear in the night, because at the night times you will see the little more compression. So that's why there is the symptoms will appear in the night, and like the severe pain would be there. Okay, there is the severe pain would be there. Then what they can ask in this, that they can ask for the test for the median nerve. The test, remember, that we will done here, that is what? That is the Fallon test. That is the Fallon test. Okay, when the Fallon test will be done, so in the Fallon test what will we have? The tingling sensation would be increased. So this is what? That is the Fallon test, that I am sending you the image in the WhatsApp. Okay, this is what? Like the opposite of the Namaste. Like this sign would be there, like this. See, this sign, like this type of the sign would be there. So this is what? That is the Fallon test. So when you will do the Fallon test, what will happen? There is the tingling sensation would be rising here. This is what? That is the flexor retinaculum, and below the flexor retinaculum we would be having the deep space would be there, through which there will be the carpal tunnel would be there. So this is what? Here we have the carpal bones. We here above the carpal bones we have the one structure that is known as the flexor retinaculum, and in this flexor retinaculum, deep space to the flexor retinaculum, we would be having there is some space would be there, that is known as the carpal tunnel. And when you will do the Fallon test, so in the Fallon test what will happen? There will be the some tingling, more pressure would be here. That's why they feeling the pain here at this region. Okay, is this clear? You can just give me thumbs up like this. Okay, then we would be having, that is the Fallon test. So remember that we have the Fallon test, that you can see in the image also, that we have the carpal tunnel, and above the carpal tunnel we have the some area of the numbness that is shaded in the blue. Okay, so the Fallon test we done for the median nerve. The Fallon test we done for which nerve? That is for the median nerve. And there is a one sign also that is known as the Tinel signs. That is known as the Tinel signs. So here what you will see, the tingling sensation would be increased. The tingling sensation would be increased. Okay, then remember that if the median nerve would be compressed, if the median nerve would be compressed, this is the extra point you can remember. If the median nerve would be compressed, so there would be the ape hand or thumb deformity, ape thumb deformity or ape hand deformity would be seen. Okay, that you can remember. So median nerve, if the median nerve injury would be there, so there would be the ape hand or thumb deformity would be seen in this condition. Okay, is this clear? Does anyone have any problem in this? Or we can repeat it. So what are these? We have the carpal tunnel. See, carpal tunnel syndrome, we having the median nerves. We having the median nerve. The median nerve, remember, the median nerve is a mixed nerve. We having the one motor supply and we having one sensory. Motor supply, they are the forearm or the hands. The forearm, we have the anterior compartment muscles which get the motor supply from the median nerve. In the hands, we would be having the thenar muscles. The thenar muscles like the flexor pollicis brevis, opponens pollicis brevis, abductor pollicis brevis, and the adductor pollicis brevis. So all these three, abductor pollicis brevis, opponents of the flexor pollicis brevis, that is supplied by the median nerve. Adductor is supplied by the ulnar nerve, that you can skip out. See, then we have the sensory supply. The sensory supply, the lateral three half of the palmar side will be having the sensory supply, and on the dorsal side the only tips having the sensory supply of the median nerve. Here we have divided them into the two branches, the deep branch and the superficial branch. The deep branch that is going deep into that, they having the motor supply that supplying the thenar muscles. They have the sensory supply that is supplying the lateral three half of the finger tips, and the palmar area that is supplied by the superficial branch. So in the carpal tunnel, this is the space that is present deep to the flexor retinaculum. There is a compression of the deep branch of the median nerve. So in the question they can ask which nerve would be damaged. So that is the median nerve damage, that is the carpal tunnel syndrome. Which branch would be there? That is the deep branch would be there. The carpal tunnel syndrome, there is no effect on the superficial branch, so the palmar sensation would be intact. In the deep branch, what are the clinical features we will see? There will be the motor atrophy of what? Thenar eminence. The motor atrophy of the thenar eminence. So what we call this is the thenar wasting. Why the thenar wasting? Because in the thenar wasting, there will be the decrease in the size of the muscles. Then we have the paraesthesia, or the tingling or the numbness would be here at the fingertips, pinprick sensation would be there because of the sensory loss. The symptoms will appear in the night or the severe pain. The test, remember, that is the opposite of the namaste, that is the Fallon test. And we would be having the next one, that is the Tinel signs. And remember one more thing, that is the median nerve will be compressed, that is the ape hand or the thumb deformity would be there. Is this clear? Okay, there is one more thing that is called the cubital tunnel syndrome. Does anyone know what is cubital tunnel syndrome? देखो, there is a cubital tunnel syndrome. We are not going to discuss in detail, just remember the cubital tunnel syndrome. And there is one more disorder that is called the Guyan canal syndrome. Guyan canal syndrome. Just remember, this is the node, the carpal in the cubital. Cubital means we have the cubital fossa. Where we have the cubital fossa? Where we put the IV line. Where we put the IV line? Here. So this is what we would be having. This is what we would be having, that is the cubital fossa. This is what that we have the cubital fossa. So remember that if you have the cubital tunnel syndrome or the Guyan's canal syndrome, what you will see, there would be the compression of which nerve? Ulnar nerve. There is a compression of the ulnar nerve. There would be the compression of the ulnar nerve would be there. Okay. So now let's see the question. Now question become very simple. So the complaints of the pain, where in the first three finger of a right hand, complaint of the pain, where the pain is feeling, pain means sensory function. So sensory function in the first three finger of a right hand over the past 6 weeks, the pain especially at the night, awakening her from the sleep. So this is what, that is the carpal tunnel syndrome. So this is the line that you have to remember. They have keep simple the first three finger, actually this first 3.5 finger, but they have wrote the first three fingers, that is okay, over first right hand over the past 6 weeks. Okay, so that is the carpal tunnel syndrome for you. Then next question, a 17-year-old patient complained of acute pain where in the knee joint, and temperature is 38 degrees Celsius. He was ill with the angina. So in the question they will give something of the history of angina, the history of pharyngitis, history of the tonsillitis 3 weeks ago. Objectively, the deformation and the swelling of the knee joint with the skin hyperemia. Hyperemia means redness. Hyperemia means redness. There are two type of the hyperemia actually. Let's little bit see little bit over here. The hyperemia means we would be having, that is the arterial hyperemia, and we would be having the venous hyperemia. So when we talk about the arterial hyperemia, of course in hyperemia means redness would be there, but arterial hyperemia, it will hot to touch. When you try to touch the localized area where we have the redness, so it will feel the hot. That means it is the arterial hyperemia. And if it is feeling cold to touch, so that means this is the venous hyperemia. This is the venous hyperemia. Small movements cause an acute pain in the joint. So what diagnosis is the most correct? If the history of the if history of pharyngitis, angina, chest pain, tonsillitis, after that the patient has developed some kind of the symptoms, the most probably it is the streptococcus group A beta streptococcus bacteria, that is streptococcus pyogenes. And in this question, history of angina is there. After that, the knee joints means there is a involvement of the joint, so that is the arthritis would be there. So most probably it will be the rheumatic fever would be there. Okay, that we will discuss like how it will be. So let's go little bit in here about the connective tissue disorder. When we talk about the connective tissue disorder, let's talk here, that is the connective tissue disorder. The connective tissue disorder. What are connective tissue? See, we have the 4 tissue in our body. One, we have the epithelial tissue, that is the outermost tissue. After that we having the connective tissue. Then after that we have the muscular tissue. Then we would be having the nervous tissue. So there the four tissues are there, and out of that we would be having the second one, that is the connective tissue, in which the bones, cartilage, everything would becomes in the connective tissue. So if we talk about the connective tissue disorder, this is a very important one. What are these connective tissue disorder? The one we having, that is the rheumatoid arthritis. One we having, that is the rheumatoid arthritis. The rheumatoid arthritis, it is the most common. It is the most common connective tissue disorder. Most common. Then we would be having the second. MC means that is the most common. MC means that is the most common connective tissue disorder. Then we would be having the Sjogren syndrome. This is J. Sjogren syndrome. Sjogren syndrome, it is the second most common. It is the second most common connective tissue disorder. Then we would be having your favorite one, butterfly, that is the systemic lupus erythematosus. ठीक है, but जहाँ पे भी दिखा butterfly, whenever you see the butterfly, what you will mark? Systemic lupus erythematosus. So this is what? The Krok 2 memory. So this systemic lupus erythematosus, after that we would be having, there is something called the IgG4 related disorder. This is the not common like for exams, so that we will not discuss. Just remember the name. Then we have the mixed connective tissue disease, and we would be having the sarcoidosis. So these all are what? These all are the connective tissue disorder, that is the related to the connective tissue. So here we will discuss about the rheumatoid arthritis, the Sjogren syndrome, and the systemic lupus erythematosus. So these three we will discuss in detail. Okay, so are you ready? So let's see here. First, let's discuss about the rheumatoid arthritis. First, let's discuss about the rheumatoid arthritis. What is the rheumatoid arthritis? The first things what comes in your mind. This is the most common connective tissue disorder. It is the most common connective tissue disorder. Or in the broad terms, if I say, it is the most common multi-system. This is the MC. So I will use this MC as the most common everywhere. So most common, that is the multi-system autoimmune inflammatory connective tissue disorder. Okay, why? So these are the multi-system, means it involves the multi-system. Multi-system means involve the all the different organs, like body. It can involve the every organs. It can musculoskeletal systems, muscles and the skeletal systems. It is the autoimmune, means it is a genetic also, and also it having some autoimmune disorder. Autoimmune antibodies are there that will attack their own antibodies. Own antigen. We have the inflammatory, means there is some inflammation would be there. You will see the some synovitis, some tendinitis. Then there is a involvement of the connective tissue, the cartilage or the bones should be involved. So all these are the connective tissue. Along with that, you will see the arthritis. Along with that, you will see there is a arthritis. What is mean by arthritis? Arthritis means there is inflammation of the joints. The inflammation of the joints. And one thing we would be having the arthralgia. The arthralgia means, can anyone tell me the difference? Write in the chat box. Arthritis and the arthralgia. Arthritis, arthralgia. Okay, arthritis means is the inflammation of the joints. Then arthralgia means this is the pain in joints. And one more important thing here, that is for your knowledge, don't compare anyone with anyone. Don't compare yourself with anyone. Maybe like your roommate or your neighbors, they are working hard or they are doing something better than you, but don't worry, If you will work hard, definitely you will overcome everything in the life. So don't compare anyone with anyone. Don't compare with anyone. So we have the inflammation of the joints, and arthralgia, we have the pain in the joints. So this, remember that in rheumatoid arthritis there is a narrowing of the cartilage. There would be the narrowing of the cartilage. The cartilage that is present between the bones, they will become narrow. And there the narrowing of the cartilage, mainly in the rheumatoid arthritis, there will be the small joints would be involved. There would be the small joints would be involved. Okay, what joints will be involved? The joints involved, and there will be some joints that will be spare. Joints spare. This is because this is very important. When we will talk about the joint spare, it means you have to remember the which joints would be spare. And if in the question, like for example, if I say that, let's first discuss it and after that I will tell you. देखो, joints involved. If I say the upper limb, if the upper limb I will discuss, the upper limbs we would be having, that is the PIP. What is the PIP? Proximal interphalangeal joint. That is the proximal interphalangeal joint. Interphalangeal means interphalangel, that is interphalangeal joint would be there, and we would be having that MCP. The MCP means metacarpophalangeal joint. Metacarpophalangeal joint. When we say the, let's see here, this is what my fingers. Here you can see there is some crease would be there. Everyone have the crease. Okay. So like if I will say that this one is what, that what is the meaning of the proximal? The proximal that is present near to the joints. Like for example, if that is present near to a shoulder, so that means this is the proximal. Let's see here. So this is what that you will see here. Dekho, this one is the proximal and this one is the distal. This was the proximal, this one is the distal. If I say this one or this one, so the proximal that is close to the joint, the proximal is one that is the close to the joint. So this one will become the proximal, this one will become the distal. This one will become the proximal, this one will become the distal to that. Okay, the away from that, away from the joint is the distals, near to the joint is the proximal. So here we can see these joints are involved. The PIP will be involved. The PIP will be involved. Along with that, you will see some metacarpophalangeal joint would be there. The metacarpophalangeal joint, for example, we would be having here, like you can see here, this is what? This is my proximal interphalangeal joint. This is my dorsal interphalangeal joint. And here what we will be having, this is the phalangeal, and we have in the metacarpal. These are the metacarpal bones. So this one is the metacarpophalangeal joint. This one is the metacarpophalangeal joint. So this joint and this joint will be involved, and the DIP, the tip one, this will not be involved. This will not be involved. This will not be involved. This will only this one and this one will be involved. Okay. So which will be spared? That is the DIP would be spared. The DIP will be spared. DIP will be affected in the osteoarthritis, not in the rheumatoid arthritis. Okay. After that, remember, in upper limbs, sometimes the elbow can also be there, but elbow, that is the rarest to join, is the rare. Then we would be having, like if we talk about the axial skeleton. So in axial skeleton, we would be having the C1 or C2 spine. Means cervical 1 and cervical 2, the joints between the cervical 1 and the cervical 2 spine, that will be involved. Then we would be having in the lower limbs. In the lower limb, remember, that is the fifth metacarpophalangeal joint. Along with that, we will see there the temporomandibular joint. And we would be having the cricoarytenoid joint would be involved. Okay, all the joint would be involved here in rheumatoid arthritis. What you have to remember, you have to remember that in this, if you want to remember just few things, just remember the PIP and MCP. Just remember the PIP and the MCP, rest forget. Okay, so all these joints should involve the C1, C2 spine, fifth metacarpo, but the most common involved joint involved, that is the PIP, proximal interphalangeal joint, and the metacarpophalangeal joint. And remember that the DIP will be spared in rheumatoid arthritis. DIP would be spared in the rheumatoid arthritis. Now, if you talk about the etiology, what the etiology means? Cause. What are the causes or the etiology of this condition? देखो, rheumatoid arthritis, it is a very vast topic. So, of course, there will be the vast etiology will be also. So, it involves the both genetic as well as the environmental factor. So, there would be the genetic factors would be there, and there would be the some environmental factor would be there. देखो, genetic factor, remember when we say that genetic factors, like there is gene would be there, so which genes? Remember DRB104 gene, and this is what responsible for the 70% cases. This is responsible for the 70% cases. And other gene you have to remember, the DR13, doctor 13, doctor first. Means DR1, DR13. These are the some genetic gene that is involved in the rheumatoid arthritis. And environmental, we have the smoking. The environmental, we would be having the smoking, or sometime we can be having the silica. Smoking is the greatest risk factor for rheumatoid arthritis. Okay, is this clear? After that, remember there is some marker also. What are these markers? The markers that will seen in case of the rheumatoid arthritis. So these are the anti-CCP, anti-CCP. What are the CCP? It is the cylindrical citrulinated polypeptide. No need to remember the full name, just remember the anti-CCP. If you don't want to remember it, of course, in the future exams they can ask you, but in the Krok they will not ask you the full form. Then simply they can give in the question, there is a keyword anti-CCP, that will be helpful for you. Or also we call this is the ACPA, that is the anti-citrulinated polypeptide antibody. Okay, so anti-CCP or the anti-CPA, these are the first antibodies that you have, or the marker that you have to remember. And this is very important for the diagnostic purpose. It is used for the diagnostic purpose. Why this is used for the diagnostic purpose? Because if you will see the specificity, of this one, that is more than 90%. More than 90% is the specific for this disorder, and this is also the best marker for preclinical inflammation. What if you see the high titer? High titer means if you doing the examination of the anti-CCP and you are seeing that is a high much amount of the this anti-CCP. So if you see the high titer antibodies, so it means that is suggestive of extra-articular manifestation. What is the meaning of extra-articular? देखो, extra means another structures. So all other, like the joints would be there, that would be affected other than the just the joint. It can spread to the other organs also. That's we call the extra-articular manifestation. Like the patients can lead to the vasculitis, the patients can lead to have the carditis, and the patients will be like there is sarcoidosis can also be there. So these are the some extra-articular manifestation in which you will see there is a large amount of the antibodies in the titer, or we call the high titer antibodies. That another important marker that every one of you know, that is a rheumatoid factor. That is the rheumatoid factor, or you know it by the RF factor. And based of that we call this rheumatoid arthritis. This is also known as the seropositive arthritis. This is also known as the seropositive arthritis. Okay, this is also known as the seropositive arthritis. Okay, is this clear? Is this clear till now? Just give me thumbs up. Okay. Okay, let's talk little bit more about the rheumatoid arthritis. That is very important. We will repeat it, don't worry. Okay. So we having the, like if the patient, we have the stages, like in the rheumatoid arthritis we have some stages would be there. If we talk the stages, we have the early rheumatoid arthritis. If we talk early rheumatoid arthritis, or there will be the loss of joint spaces. There will be the loss of joint spaces would be there. If there is a later stage, in the later rheumatoid arthritis or in the later stage, what you will see the deformities, and these deformities has been asked in all the exams. Whatever you will prepare, these rheumatoid deformities will be asked. When you say the rheumatoid arthritis, you will see the three things. You will see the synovitis. What is the synovitis? Means inflammation of the synovial joints or inflammation of the synovial fluids. Then we would be having the tendinitis. Tendinitis means the inflammation of the tendons would be there. Then we would be having the bursitis. They have the bursa also, so the inflammation of these bursa would be there. That will be the bursitis. So this is what we will see in the rheumatoid arthritis. Then we will talk about some deformities. Deformity that is important for your exam, that is zigzag deformity. The first one, the earlier or the first change that will, first deformity or the first change you will see in the rheumatoid arthritis, that is the zigzag deformity. Zigzag deformity. Here you will see the ulnar deviation, due to ulnar deviation of the fingers. Means fingers will be deviated towards the ulna and the metacarpophalangeal joints will be deviated to the radial side. So that is the zigzag. Other deformity, just remember the name, that is the piano key deformity. That is the piano key deformity. I will share you all the images. Then we would be having the third one, that is the Hitchhiker thumb, or we call this as the Z-shaped deformity. We call this as the Z-shaped deformity. What is the meaning of the Z-shaped deformity? See, this is the deformity of the thumb. That's why I have given the name also Hitchhiker thumb. Okay, thumb is there. So what you will see here, there will be the abduction and hyperextension of thumb. Abduction and the hyperextension of the thumb. Till now it's little complicated. Okay, why this little complicated? Because all these deformities are reversible. All these deformities are the reversible. Now जो अभी deformities आएंगी, now this whatever deformity will be coming, so they will be non-reversible. They are the non-reversible deformity. Means we can't reverse them. What are these? These are the swan neck. So the what is swan neck deformity. The swan neck deformity would be there. So in the swan neck deformity, what you will see, there will be the hyperextension of the PIP. I told now which joint would be involved, PIP or मेटाकार्पोफेलेंजियल जॉइंट्स, है ना। So in the Swan neck deformity, what you will see, there would be the hyperextension of PIP. The hyperextension of the PIP would be there, and the DIP here would be flexed out. There is a flexion of what? DIP, that is the dorsal interphalangeal joint. Then remember that the second one, that is the botonier deformity. Botonier deformity, it is the opposite of what? Swan neck, that is the flexion of PIP and the hyperextension of DIP. Okay, so that is the Bottonier's deformity. Okay, then the next one, we have the treatment. What the treatment? Remember, the treatment we will give, that is the anti-tumor necrosis factor alpha. Like examples, we can give the infliximab, and this is your question in the Krok 2 also, the infliximab and etanercept. So remember just these two drugs. Okay, now I will show you some images. So in this image you will see all these three things. Let's see this patient. Check your WhatsApp. See this, in this is the later stage. So what you are seeing here, that the Bottonier's deformity of the thumb, where what you will see, there is a what you will see in the Bottonier's deformity, there is a flexion of the PIP and hyperextension of the DIP. So you can see the DIP joint, that is the dorsal interphalangeal joint. So this is what hyperextended. Hyperextended means stretching out. Okay? Flexion means towards. Like when the two body parts are coming together, so it means flexion. And I hope you are not confused in the flexion. This is what, when the two body parts are coming together, like if I will make the two joints here, so this will become the flexion and this will become the extension. When the two body parts will go away, so that will be called the extension. So here you can see that there is a Bottonier's deformity of the thumb, and there is a ulnar deviation of the metacarpophalangeal joint, and there is a Swan neck deformity of the finger. In the Swan neck deformity, what we are seeing, hyperextension of the PIP and the flexion of what? DIP. Okay, is this clear? Piano key deformity. Okay, piano key I will share you all other image. Okay, so these are the main images that you have to remember: the Swan neck deformity, zigzag deformity, and the Bottonier's deformity. The Swan neck deformity, the hyperextension of the PIP, then flexion of the DIP. Bottonier's deformity, the flexion of the PIP and hyperextension of the DIP. So these are the non-reversible deformity that you will see in this patient. Okay, and the treatment, remember, that is the infliximab. Is this clear? Okay, let's repeat it. See, rheumatoid arthritis, we would be having the most common connective tissue disorder. Then we have also that involve the multi-system. So the most common multi-system autoimmune inflammatory site connective tissue disorder. This is the autoimmune condition, this is the inflammatory condition, and it involves the multi-systems. What you will see in the rheumatoid arthritis, there in the between the joints we will be having the cartilage. So the cartilage will becomes narrow. So that's will seen in the rheumatoid arthritis. There, in the later stage, there is a lots of the rheumatoid nodules will also be formed, but I have not make it so much stretch. Whatever the importance we have discussed. Otherwise, it's very long topic. Then we have the small joints would be involved, and along with that you will see with the arthritis. The main thing that you have to remember in this question of rheumatoid arthritis, that the joints will be involved, the PIP and the metacarpophalangeal joint, that will be involved. Then if you talk about the causes, we have the genetic factors. Genetic factors you have to remember the DRB04, DRB104. This is the DRB104. DRB104. That is what 70% cases we will see this is the genetic factor. Then you will see here that is the DR13, Dr. 13 and Dr. 1 gene. Dr. 13 and Dr. 1 gene is responsible for which condition? So 13 what you can make? 13 you can make the R. So that will become the 13. Then 1 you can make the R. So that will become the again rheumatoid arthritis. Okay? Now environmental factor we have the smoking and the silica. Smoking and the silica. Alcohol is the protective factor. The alcohol is what? Protective factor for rheumatoid arthritis. Then after that we will be having the markers. What are the markers? Anti-CCP, anti-cylindrical citrullinated polypeptide, or the ACPA. ACPA it is anti-CCP or ACPA used for the diagnostic purpose. The specificity is more than 90% and the best marker for the preclinical inflammation. If you see the high titer, it means it suggests that there is an extra articular manifestation. Then we would be having the rheumatoid factor is there. And rheumatoid factor, remember, we call this why if the rheumatoid factor is positive, we call this condition as the seropositive arthritis. So this is another name of what? Rheumatoid arthritis. In early stages, you will see the loss of the joint space. Why the loss of spine space? Due to narrowing of the cartilage. Then later stages, what you will see? Deformities. What are the deformities? Zigzag deformity. You will see the piano key, hitchhiker thumbs, or the Z-shaped deformity. Or this is the Z-shaped deformity that is shown in the question. That is hitchhiker thumbs. Here the botoner deformity of the thumb. So this is also the Z-shaped deformity also. Here you can see the abduction means away from the body and the hyperextension of the thumb. Then we have the swan neck deformity, where you see the hyperextension of the PIP and the flexion of the DIP, botanist deformity, that you have to remember. And remember, believe me, this is the very important point. Very means very important point for all the exams. What is osteoarthritis? That name is suggesting. The osteo means bones, arthritis means joints are there. So remember that this is the most common joint disorder. The most common joint disorder. This is not the connective tissue disorder. This is the most common joint disorder. Okay, why I am telling? Because the involvement of the joints like PIP, DIP. So that should be clear here. And this is also known as the degenerative process of cartilage. Degenerative process of cartilage. It means here the cartilage would be damaged. I am right, sir? Yes, sir. So the cartilage would be damaged. And remember that if the cartilage would be damaged, so it means bones will rub with each other. Because what's present in between the bones? In between the bones, we would be having loads of cartilage. And in this cartilage, when the damage, so the bone will start to rub with each other. The bone will start to rub with each other. So bone and will rub with each other. And you know, though, when the friction comes, the frictions will generate the some problems and will create some problems. Like in our normal life also, friction gives the resistance. So whenever the friction comes, it will be provide some resistance to our if in our life we are getting some kind of the friction, that will provide us the resistance, that will stop us for going forward. So the cartilage, the damage, the same thing, the bones and will get a lot of the frictions and they will rub with each other, and when they will rub each other, there will be the pain would be there. And when the patient, like for example in the question they will give the history, like the patient is doing the squatting, and when the squatting is done, the sound would be produced. So sound during the squatting, and when there is the sound during the squatting, there would be the, see, whenever the bones there will rub with each other, so the density of the bones will be increased, the bones will become more harder, that will call the sclerosis, means the density of the bones would be increased. And if all this, if it completely doing rubbing with each other, there will be the little bit necrosis also, and the bones will be completely tied to tendons. What the cause of this condition? Why the cartilage damage? See, this is what the age-related degeneration. Age-related degeneration means when you saw when the old uncle or auntie, what happened with them? They will feel like that they having some kind of the problem in the joint. They feel that I can't stand up easily. I can't sit up easily. They have the pain in the knee. So that is what, that is the maybe osteoarthritis. So this is the age-related degeneration, and there will be the sometimes there the pre-existing destruction of the cartilage. Pre-existing degeneration of the cartilage. Then if we talk about the types of osteoarthritis, remember there will be the two types. One, we will be having the primary, and the primary osteoarthritis, it means there is, whenever we will see the types, and in the types we see the primary or the secondary, it means that primary means the cause is primary, means the cause is little bit around that joint or something like that, and the secondary means some other pathology would be there. Like funny, if the joints are there, it can be the secondary pathology. For example, any pre-existing joint pathology is there, so due to which we are getting the osteoarthritis. Okay, whether it's the rheumatoid arthritis, whether we are the systemic lupus, any connective tissue disorders, any lung disorders, any heart disorders, whatever the problems are there, and due to which we are feeling the osteoarthritis, so that is the secondary cause. And primary means we would be having the idiopathic. What is the meaning by idiopathic? Idiopathic means the cause is unknown. We don't know about the cause. That is what idiopathic. And this is idiopathic. This is the most common cause. This is the most common. Dekho, in medical life, you will see the two terms about the II. So that is the one is idiopathic and one is what? That is the iatrogenic. Idiopathic means the cause. Idiopathic means unknown. We don't know about the what are the exact cause. So that means unknown. Then we would be having the iatrogenic. Iatrogenic means that this patient is having some problem because of the doctors. Okay, the doctor's fault are there. Doctors or any nurse. Basically, it's most of the doctors only. So the doctors or nurse problems, or you can like the fault. Like if the doctor is doing some kind of the operation and he forget maybe some seizures inside the, or the some syringe inside that during that operation inside the body. So that will become the iatrogenic cause. Okay, and after that there is some hemorrhage are there, some bleeding would be there, so it will become the hemorrhagic causes. Okay, here we are going, let's come to our topic. In osteoarthritis we have the two types, primary and the secondary. The primary we have the idiopathic, that is the most common. Then remember, we having the primary, we would be having the localized. Localized means only involved on joints. Localized means only involved on joints. And which is the most common joints are involved? That is the most common is what? Knee joint. That you have to remember very precisely. See, in osteoarthritis, which is the most common joint is involved, that is the knee joint. The most common joint involved in osteoarthritis is what? That is the knee joint. Then we would be having the, after the localized, we having the generalized. That is the generalized cause. The generalized, remember, that is means when the more than 3 joints are involved. And therefore the generalized, the most common generalized cause is what? That is the DIP. That is the DIP. And this is the most common joint that will be involved. Why the secondary? Secondary is due to some pre-existing pathology. Pre-existing joint pathology. That will cause the secondary osteoarthritis. Okay, this is due to. This is the most common. Okay, so you can remember the DT. I will write for the due to. So this, we have the types, so the two types, primary and the secondary. The primary we will have the cause is idiopathic, and the secondary it is due to pre-existing joint pathology. What you will see in the clinical feature, when there the necrosis would be there, clinical picture. What you will see, like here we have discussed that this patient would be having the pain sound during the squatting, the sclerosis would be there, the density will be imposed, and after that the bones will going under the necrosis, and after that if the necrosis would be there, the patient would be lead to having some clinical features would be there, and these clinical features, what will be there? There will be the pain on active and passive movement. Whenever there will be some movement would be there. What is meaning by the active and the passive movement? The passive movement when there is no energy used, but active movement when there is some energy would be there. So that would be the active and the passive movement. Now, if there is a pain is there, of course there would be the decrease the range of the movement. The person will not able to have some more movements. Like if I will say that I have the pain in my elbow. Okay, if I have pain my in elbow, so what I will do? I will try to do it like this, and I will go, or like if I have the pain like problem and I will have the pain. If I have pain, I will go like this only. I will not try to do in my pain. I will not go like complete flexion. So I will do some kind of the limited movement. I will do some kind of the limited movement would be there, and due to this limited movement, what will be there? There is a decrease in the range of movement. If there is a decrease in the range of movement, of course the muscles use would be decreased. The decrease in the muscles use, the muscles will not able to work properly, so the muscles use will be decreased. Okay, and there you will see that will call the disuse atrophy of the muscles. The muscle size would be decreased. Disuse atrophy of the muscles would be there, and this will help you, like this kind of the finding will help you in the exam in one of the question. Like in the question they will say something, there is a decrease in range of the movement, decrease the muscles usage, so what kind of the atrophy can be there? So this is the disuse atrophy of the muscles. Okay, after that what other symptoms you will see? There will be the crepitation. It's like the sound will be there, like the scratching, because of the decrease of the cartilage, so there will be the crepitations, and then the swelling and the deformities. Or deformities again we are getting here. Deformities we have discussed already. Zigzag deformity, we have discussed about the swan neck deformity, boutonniere deformity, but sir, that was in the rheumatoid arthritis. We were discussing here about the osteoarthritis. So in the osteoarthritis, there is a two deformity would be there. What are these two deformity? These are the bouched nodes. These are the Boucher's nodes, and we would be having the Haberden nodes. Did anyone of you know how to measure the BP? Right deformity is also related to rheumatoid arthritis. Note that right deformity, like it's specially for the like nerve injury. Okay, tell me about that. What was what was I asking? So Boucher nodes and the Haberden nodes. Like what kind of you see? I was asking about the BP. So any one of you know how to measure the BP? Give me a thumbs up or down, whatever. No. So here I will telling you that BP is measured in HD. BP is measured in HD. What is this? Let's see here. So B is here, H is here. So remember that here in the Boucher nodes we would be having the PIP. We have the PIP. PIP joints will be involved, and in the Haberden nodes we would be having the D, that is a DIP, that is joints. DIP joints will be involved. So in Bouchers, what you will see, there will be the BP. Can you see here? That is the BP, BP. B is here, P is here, B is here, P is here, H is here, D here. So remember that BP in HD. How you will measure the BP? You will measure the BP in HD. So this is the mnemonics to remember. The Boucher nodes, the PIP joints will be involved. Haberden nodes, DIP joints would be involved. Okay, if I say, okay doctor, do the X-ray. You are going for the X-ray and you have done the X-ray, and in the X-ray what you will see? Can you please tell me what you will see in the X-ray? I know you can tell me. The first thing what you will tell, sir, the bones are joining with each other, so there is no space is there, so the decreased of what? Joint space. There will the decrease in the joint space would be there. Sir, there is a bone is there, one bone is there, another bone is there, there is no cartilage, no space is there, so it feels like the bone is on other bone. So it means it will give the bone on bone appearance. Sir, whenever there is the no space, so there would be the, sir, there will be the density of the bones would be increased. So whatever the cartilage that is present below the bones or the surrounding the bones, sir, there will be the some density would be there. So we will see the sclerosis also, and we call this as the subchondral sclerosis. Means density of the bone would be increased, hardening of the bone would be there. Okay, so you have just told that once the, like here we have discussed, so you just told that pain, the sound during the squatting, the sclerosis would be increased, the necrosis would be there. So sir, necrosis can we see? Yeah sir, necrotic cyst would be there. Dekho, these then the necrocyst would be there, there will be the release of osteophytes. So you will see some necrotic cyst, and along with that you will see the osteophytes. Now these osteophytes will be free and they will be seen as the loose bodies. They were seen as the loose bodies. Okay, and these loose bodies will travel to the whole body. So that we will see on the X-ray. So let's see here first again that osteoarthritis, it's the most common joint disorder. This is also known as the degenerative process of cartilage. The degenerative process of cartilage in which the cartilage will be degenerated. So this is what the age-related degeneration. This is the age-related degeneration. means once the person will be growing up, there will be the chances of the cartilage degeneration, and there can also be some pre-existing degeneration of the cartilage can also be possible due to some pathological reasons. Then we have what we'll see, the cartilage damage. So the cartilage would be damaged, the bone will rub again with each other, the pain would be there, the sound will be there during the sweating, the crepitation would be there, sclerosis would be there, the necrosis would be there, and these necrosis, the osteophytes will be released out, the loose body will be spread out through the body, that will also seen on the X-ray. And the types, we know that the primary idiopathic, most common joint is knee joint, and we know the secondary pre-existing joint pathology, crepitation, and clinical feature we have discussed, decreased muscles movement, so muscles atrophy will be there, crepitation would be there, swelling or the deformity. Or sir, deformity you have just also told us very simply, BP in HD. So Boucher's nodes or the Haberton nodes. So Boucher nodes, PIP joint will be involved, Haberton nodes, DIP joint will be involved. So BP in HD. Okay, so that means BP, right? You will measure the BP in HD, you will never forget it. And remember the Bouchard, है ना, क्या बोलते हैं अगर like in the some mental person are there, butchered person, है ना, butchered person is there, and this is the Haberton person. The butchered or one Haberton means Haberton looks like the some professional type. So the butchered means some mental person, butcher type. So in the butcher type, you know the BP, that is the PIP joints, and Haberton's it looks like the professional. So you will understand the HD means that is the DIP joints will be involved. The metacarpophalangeal joints are involved or not? Chalo, just give me thumbs up or thumbs down that metacarpophalangeal joints are involved in osteoarthritis or not. Are you listening? Okay. What was the name? Sorry, something like Rukoya. So that is he is correct. So what is that we would be having? So that will be like metacarpophalangeal joints would be spared in osteoarthritis, that will be not be affected. Okay, is this clear till now? Why is there crepitation? The cartilage would be damaged, the bone end will rub with each other. Now tell me, if there will be the no joint space would be there, the bones will start to having the let me just figure you out for something. Can you hear some sound? So this is what, that's the crepitation. See, these are the some joints. Okay, these are the two bones, and between these bones you see there is a no space are there. Like firstly there was a space, so once ever there will be some joints would be there will be the no sounds would be there. But once what happened, there is a no space would be there. Now there is a no space, and whenever there will be the like the bones will start to join, there will be the some sound would be there, and this sound is known as the crepitation. This sound is known as the crepitation. Like this sound would be known as the crepitation. Okay, so this is what we would be having rheumatoid arthritis, and we would be having the osteoarthritis. Okay, now let's go to our questions, that is about the acute rheumatic fever. Where my pen? So see, let's continue with the one more important disorders, that is acute rheumatic fever. Acute rheumatic fever. And what are the topics we are going to discuss, that the demo classes that I am taking for why I am taking this rheumatology classes, because out of this you will get around 2 to 3 questions is 100%. Definitely there will be the exams, and there can be 5 to 6 question also can be there from this small topic. Okay, and this is not just important for your just Krok 2 exams, it will definitely will help you in the future exam as well, in all other future exams, because this rheumatology, like in every exam you will get the question rheumatoid arthritis or acute rheumatic fever, infective endocarditis. So these are the very important topic or higher topics for all exam. So remember that we would be having acute rheumatic fever. So whenever the acute rheumatic fever will becomes, there is one bacteria is there that is very culprit bacteria. So this is what the group A streptococcus bacteria, that is the group A streptococcus bacteria. I hope you are not tired. We will just do the acute rheumatic fever today, because I know this is the first class, so we will not go much hectic. So this is the group A streptococcus bacteria, that is the streptococcus pyogenes. Streptococcus pyogenes. देखो, this bacteria is very culprit bacteria. They will cause the suppurative disease, like that is involving of the bacterial infections. They can be some non-suppurative. देखो, when we discussed about the suppurative. Suppurative means some bacterial infection, pus cells would be there. So that is the bacterial things. But here they can cause the non-suppurative. In the non-suppurative, we would be having like the rheumatic fever. We would be having the rheumatic fever would be there. Okay, and we would be having that is the glomerulonephritis. Okay. Rheumatic fever will be preceded by the sore throat. Like in the question, you will getting the history of the sore throat, pharyngitis that I have discussed you before, or the angina, the glomerulonephritis. There will be history of the preceded by sore throat, or it can be the skin infection as well. And it can also cause the toxins, like they will produce they are the gram positive bacteria, so they will be having the some toxins would be released by them, so they will be the toxin mediated disease will also be caused by them. So when we talk about what the pathogenesis behind that, what are the etiology or the causes of the acute rheumatic fever. So remember that this is the ARF, that is the acute rheumatic fever. This is that the immune mediated multi-system disorder. Immune mediated multi-system disorder. What happened? Why the immune mediated? Whenever there will be we having some throat infections, like for example, if the patient would be having the untreated streptococcal throat infection, streptococcal throat infection would be there. Like for example, it's for 2 to 4 weeks. So what will happen if the patient is having the history of the sore throat or the pharyngitis? What will happen in this condition? This patient will be having the non-suppurative inflammation. Non-suppurative inflammation will be there, like of the joints, heart, skin, CNS, subcutaneous tissue will be there. Then this inflammation will resolve spontaneously. Sir, you are saying there is a non-suppurative inflammation, after that this inflammation will resolve spontaneously. What kind is this? See, there is a, it will be inflammation few weeks to months. So there will be no residual change. देखो, non-suppurative inflammation will seen in the joints, heart, skin, CNS, subcutaneous tissue. So all these will be inflamed. So in the heart, you will see the patient would be having the carditis, the joints polyarthritis, arthralgia would be there. In the skin, we will see some kind of the nodules would be there, like the subcutaneous, and the CNS, we will see some kind of the, like the not so much problem in the CNS, and the subcutaneous tissue, we will see there is a subcutaneous nodules would be there, the erythema marginatum would be there on the skin. So these kind of the things we will see. So, but these inflammation will be resolved spontaneously few weeks to the months. So there will be no residual changes. So what things you will see here, there is exception here, that is the carditis. So that will not be resolved. So this will lead to the rheumatic heart disease. This is known as the rheumatic heart disease. Okay. Because this is little bit lengthy topic. I can finish this in the very major criteria, minor criteria also, but you have to remember this. There is a one theory behind that. The theory behind that is the molecular mimicry, that is the most accepted. That the molecular mimicry. What is the happen in the molecular mimicry? There is a certain antigens of the, like for example, if we say the streptococcus antigens are there. Streptococcus pyogenes antigen will resembles the human antigens. So what will do, when this antigen or when this streptococcus pyogenes will enter in our body, so it will lead to the antibody formations, and these antigens, it resembles the human antigens that is present in our body also. So what it will do, it will act as autoantibodies. So it will act as autoantibody. So this autoantibody will bind to human antigen. This bind to the human antigens, and when the antigen or the antibody will be formed, there would be the immune complex formations. Can you tell me what type of hypersensitivity would be there? Immune complex hypersensitivity. Please don't make me disappointed. What kind of hypersensitivity is immune complex hypersensitivity? Type 2. Immune complex is the type 3 hypersensitivity. Immune complex is the type 3 hypersensitivity. Type 2 is antibody mediated. So when this autoantibody will bind to the human antibody, immune complex will be formed. So there would be some inflammation would be there. Some inflammation would be there. Okay, so that is the molecular mimicry, and that will lead to the acute rheumatic fever. Now remember that. So can we say that this is the hypersensitivity reactions? Can we say the acute rheumatic fever is the hypersensitivity reaction? Of course, yes, because in this condition we will see there will be the immune complex formation would be there. So this is the hypersensitivity reactions to group A beta hemolytic streptococcus, GABHS. So So you can write it here, hypersensitivity. Write the full form, hypersensitivity. Hypersensitivity to group A beta hemolytic streptococcus. And in short forms it's write as GABHS. Okay, that is the group A beta hemolytic streptococcus, or that is known as the streptococcus pyogenes. There is a one criteria that you have to remember to diagnose the acute rheumatic fever, and that is known as the Jones criteria. That is known as the Jones criteria. देखो Jones criteria, we would be having some major criteria would be there, and we would be having the minor criteria. There would be some major criteria would be there, and we would be having some minor criteria would be there. देखो when we talk about the major criteria, in the major criteria we would be having the Jones, JONES. Okay, so that is what you have to remember. So J for what? That is the means joint would be involved. There will the joint would be involved, and the joint, remember, there will be the migratory arthritis. You will see the migratory arthritis. Means what the migratory arthritis? Sometimes they will say, the patient will say, Doctor Saab, I have the pain here before, then the pain migrate to my elbow, then pain migrate to my carpal, or this wrist joint. So first the pain was on the shoulder joint, then the elbow joint, and then there was the pain in the wrist joint. So this is what? That is the migratory arthritis. Migratory arthritis. देखो in major criteria, remember, we would be having two conditions you have to remember. This is the some country or the some areas in country that is the high prevalent, and the some areas that are the low prevalent. That you have to remember, because if you will be want to remember the directly, just remember these things. If you want a little bit more, then do it this one: low prevalence area and high prevalence area. High prevalence area, like India is also in the high prevalent area. So joint like migratory polyarthritis, we will be having like if the in low prevalence area. Hello. Okay. So this is the polyarthritis. This is the polyarthritis. Then high prevalence area, this is the polyarthritis or monoarthritis or polyarthralgia. What does it mean? देखो, whenever like in the high prevalent area, like in the India, if you will see some kind of the monoarthritis, if you see there is a one single joint involved are there. In I have seen the many patient in the Ukraine having the rheumatoid arthritis. So this is, we can say, I think that is the high prevalent area. In the last year, I have seen many patient was there for rheumatoid arthritis. So if high prevalent area, you see the single joint inflammation, you can categorize it into the Jones criteria. But in the low prevalent area, you will consider only when the patient would be having the polyarthritis. Means the multiple joints are involved, then you will consider it as the criteria of the Jones. Then O4, we would be having the heart. O can we make the heart, we can love, so that is the heart. So in the heart, remember, we would be having that is the carditis. That is the carditis. And the most common valvular lesion, remember, the most common valvular lesion in rheumatoid arthritis. So that is mitral regurgitation. Mitral regurgitation. But in the Krok, remember, for the Krok, mitral stenosis is the most common than the mitral regurgitation. I don't know how, but actually this is mitral regurgitation, that is the most common valvular lesion in the rheumatoid arthritis. But for the Krok questions, assume that the mitral stenosis is most common valvular lesion in rheumatoid arthritis than the mitral regurgitation. Okay. Then remember that we would be having the NES, that is the N. So remember that what is the N? I hope you are not tired. Just take a deep breath and out. Take a deep breath and take out. Then we have the N. So N, what you will see, there is the nodules. The nodules would be there. What are these nodules? These are the subcutaneous nodules. The subcutaneous nodules would be there. And remember that these subcutaneous nodules, they will present where? In extensor surface. They will present on extensor surface. Then after that we would be having the E. That is the E means we have the erythema marginatum. We would be having E4, that is the erythema marginatum. The erythema marginatum, it present basically at the site, that is the trunk, extremities, the upper and the lower extremities. What you will see here, the red color margin of the rhesus. Red color margin of the rhesus. Check out the image. Okay, we have not shared the Haberden or the Bouchard note. First, let's see the Bouchard note. And here we have the erythema marginatum. So check your group. See, these are the Haberden notes where we'll see HD. So means Haberden notes at the DIP joints you can see, and the Bouchard notes you can see on the PIP. Okay, and this is the patient image where you will see the Haberden and the Bouchard notes. The next one is what? That is the erythema marginatum. Let me write it here. Okay, so these are what? These are the erythema marginatum. So you will see there is a skin is there, and the skin having some kind of the redness would be there. So this the red color margin of the rhesus, this is known as the erythema marginatum. This is known as the erythema marginatum. Okay, then we have the S. S for, remember, this is the syndham chorea. Syndham chorea. Syndham chorea will see there will be the IgG antibody would be there against the basal ganglia. In syndham chorea, there is the IgG formation against the basal ganglia. Okay, so you can remember which antibody if you will forget. So remember the Suno G. Okay, Sun G, Sun OG, Sun OG. So remember that is Sun G. That is means IgG antibody would be there. What you will see here, the patient would be having the external hand rotation. There would be the external hand rotation would be there. Like typically this is known as the scooping. And the patient will see the alternate squeeze and release. The alternate squeeze and release would be there, or we call this as the milky action. Okay, so remember that the very important point of the syndrome chorea. So this is what, that is the late manifest. This is the late manifestation. This is the late manifestation, and remember that this is common in females. This is the common in females, and there is the decrease in sleep. For the treatment of this condition, the treatment is what? Sedation. We have to give the sedative drugs to the patient for the sleep. So remember that the syndrome chorea, this is a very important feature. So remember that in case you will see the external hand rotation. Wait, if I will send you the okay, you can see, you can see my screen, my mobile screen. Okay, so here you can see, so this is what you can see here, that is the case of the syndrome chorea. Okay, so this you can see the external hand rotations, and also you will see there will be the some same moment, the squeeze and the release moment, the same like in this patient you can see the external hand rotations, and you will see the patient will be having the same kind of the rotation would be there, that is called the squeeze and the release. This one, it going to the external rotation of the hand. One more picture here you can see. So this is the movement that you are seeing here in this, the shoulder movement you are seeing here. There is a milky actions, like means the patient have the repeated movements, like the repeated kind of the movement. This is also the part of the syndrome chorea. Okay, see, firstly she was doing with the right hand, now she is doing with the left hand. So she want to teach us by the both hands. Okay. So what is that? That is the late manifestations common in the films, and there is a decrease in the sleep. The treatment is what? That is the sedation. So these are the some major criteria. Now we would be having some minor criteria would be there. Minor criteria. See, when we see the minor criteria again we will see the low prevalence area and the high prevalence area. And for this we have the very important things you have to remember about the low prevalence and the high prevalence. See, the first things in the minor criteria we would be having, that is a, you can remember it with the help of ACP, that is the A4 we would be having the arthralgia. The arthralgia is what? That is the polyarthralgia. It is what? That is the high prevalence area. It is the major criteria. But in the arthralgia, in the low prevalence area, it is the minor criteria. Polyarthralgia. Here the monoarthralgia will be considered as the minor criteria. Okay. Then we would be having the next one, the C4 we have the C-reactive protein. C-reactive protein would be there, and the C-reactive protein would be increased. Here will also be, should be increased. Then the P4, remember we have the PR interval. PR interval of the ECG. PR interval in the ECG. So it will be prolonged in both. It will be prolonged in both. Okay, after that we would be having the ACP. F means that is the fever. So fever we would be having more than 38.5 degrees Celsius, that is the low prevalence area, and in the high prevalence area if it is more than 38 degrees Celsius it is considered as a minor criteria. Then we would be having the E4, we would be having the ESR. Okay, ESR means we would be having that is the more than 60 here and the more than 30 in the high prevalent area, it is considered as the minor criteria. If you don't want to remember the low prevalence, high prevalence, just remember arthralgia, CRP, PR interval, fever, ESR. These are the minor criteria. How you can remember it well? That the Jones make the FIR in for ACP. So ACP FIR. So FIR, instead of FIR you can write it FER. Okay, just remember that. Okay, the ACP, that is the FER would be there, that is the minor criteria. Is this clear? Only just 20 minutes and then we will finish. Okay. So then how you will make the definitive diagnosis? You know that you saw in the question that the patient has the fever, you saw the patient would be having the syndrome chorea is there. So how you will make the definitive diagnosis? See, the definitive diagnosis will be made with the help of two major or. Two major or means one major plus two minor. Okay, so there is a two major, either there is a two major or one major plus two minor criteria should be there for making the definitive diagnosis. Like for example, if the patient has the polyarthralgia, high prevalent area is there, polyarthralgia is there, carditis is there, it means this patient is having the acute rheumatic fever. And if you see the patient is having the like one major, like if the patient having the fever, the increase of the CRP is there, and along with that you see the patient having the erythema marginatum, so it means this is the one major criteria is there fulfilling and the two minor criteria are fulfilling. That means this is the making the diagnosis of the ARF, acute rheumatic fever. So you can remember it well, the Dubara. Okay, 212, 212, 212, 212, 212, 212, 212. और in हिंदी you can remember दो बारह, ठीक है, दो बारह. चलो दोबारा. So 212, 212, 212, 212, 2 2, 2 2. So that you have to remember. 2 means you have the major criteria and 1 plus 2. So these are the minor criteria. So they make the definitive diagnosis. Okay. Along with that, you should have the essential criteria also. The essential criteria means you should have know that this is the actually this is the streptococcus bacteria or not. Okay, so there should be the evidence. Without evidence of the, this should not be there. The evidence of the prior streptococcal infection. So what like that? There should be the, like you will take the throat culture, or there will be the anti-streptolysin O antibody will be more. What are these? Anti-streptolysin O antibody, or we can say the strap antigen should be positive. The strap antigen should be positive. So these are the essential criteria. If there is no essential criteria, we should not going for the definitive diagnosis. Agar if in the question the syndrome chorea is present, then essential criteria is not needed, because essential syndrome chorea, it is a late manifestation. So for that the essential criteria is not needed. Okay. Okay, then prophylaxis of the acute rheumatic fever we will do it tomorrow. And okay, so otherwise it will become too low. See, let's me revise it fastly. The acute rheumatic fever, this is the culprit of this many disorder, that is the group A beta hemolytic streptococcus bacteria, that is the GABHS. So they will cause the suppurative, non-suppurative and the toxin mediated disorder. So what you will see here in this condition, you will see the patient would be having the rheumatic fever, or they can cause the glomerulonephritis. Basically they cause the post-streptococcal. This is known as the post-streptococcal glomerulonephritis. So these both patients will be preceded by the sore throat, skin infection. Acute rheumatic fever, what you will see, there will be the immune mediated multi-system disorder would be there. The hypersensitivity reactions to the group A beta hemolytic streptococcus. So what you will see here, the untreated streptococcal throat infection, they have the non-suppurative inflammation, joint, head, skin, CNS, subcutaneous tissues. The inflammation will be resolved spontaneously like that few weeks to months, but except the carditis. And if the carditis is there, we call this condition as the the rheumatic heart disease. We call this condition as the rheumatic heart disease. What is the theory behind the acute rheumatic fever? That the molecular mimicry. When the streptococcus pyogenes antigens will enter in our body. So this antigen will resembles our human antigens. So our body will try to do, they will form this antibody formation, and this antibody will be act as the auto antibodies. So they will bind to this human antigens. So they will bind to human. So this antigen will bind to this human antibodies or the human antigens. These auto antibodies will bind to the human antigens, and then antigen antibody complex would be formed, that is known as the immune complex, and after due to which you will see the inflammation would be there. Then criteria, remember we would be having the Jones criteria would be there. In the Jones criteria we have the two criteria would be there, the major criteria and the minor criteria. The major criteria, there will be the joint involved will be there, heart would be involved. The joint, remember, the migratory arthritis, and heart we would be having the carditis. Other feature that you will see here, that is the nodules, subcutaneous nodules. Mainly these subcutaneous nodules will be present on the extensor surface. Then we would be having the erythema marginatum. This erythema marginatum, they will present on the trunk or the extremities, and they will be having, they also present on the red color. They are this finding. There is a like this red color margin of the rhesus. So this is what, that is the erythema marginatum. So you will see the red color margin of the faces. No, it will be like this, empty. So it will be like this. So then we have the syndrome chorea. Syndrome chorea means that the repeated movements would be there. The patient will see alternate squeeze and release, alternate squeeze and release, alternate squeeze and then release. External hand rotations like scooping would be there. Then the late manifestations would be there. This is the late manifestation common in the female. The decrease in the sleep would be there. And remember the diagnostic criteria, that is the 2-1-2. And the essential criteria, that is the anti-streptococcus O antigens would be positive. This is the external hand rotations. Like if I wanted to take something like that, so I will do like this, scooping. So this is known as a scooping. So this is the external hand rotation. This is the external hand rotation, and this is the milking and squeezing. Milking, squeezing, milking. Sorry, if I'm putting it. So this is what, squeezing and release, squeezing and the release. So this will be like some alternative or the repeated movement that you will see in this patient. And if the syndrome chorea is there, essential criteria is not needed. It means that patient has definitely acute rheumatic fever is seen in this patient. Okay, is this clear? WhatsApp group. In WhatsApp group, I have shared all the images. Wait, let me check if they are or not. You are there, right? Okay, now let's see our question. In the question, we would be having some knee joints is there. The patient is angina, like the chest pain. Angina basically that start with the pharyngitis. Objectively, the deformation and the swelling of the knee joint with the skin hyperemia, small joints cause an acute pain in the joint. So this is followed by the preceded by the some sore throat. So that's why it is the case is the acute rheumatic fever, and there will be the involvement of the joints. There is swelling of the knee joints are there, and there is a small movement in the joints. So the involvement of the multiple joints is there. Here you can see the knee joint, the acute pain in other joints. So this is what there is the polyarthritis condition. Okay, systemic lupus erythematosus we will discuss tomorrow. Reactive polyarthritis we will discuss tomorrow. Reactive rheumatoid arthritis we have already discussed. Let's see the one question on the rheumatoid arthritis or the osteoarthritis. This is basically the same question about the acute rheumatic fever, where see the apical murmur are there. So anti-streptolysin O antibody, like acute rheumatic fever. We will discuss it again, no problem. See this question. A 60-year-old patient complained of the pain in the interphalangeal joint of the hand that got worse during walking. Objectively, the distal and the proximal joints. So we have seen these are DIP and the PIP are involved. DIP and PIP. So you can rule out what? This is not the rheumatoid arthritis. Not the rheumatoid arthritis. So what you have seen, the Haberden and the Bouchard nodes. So now it's clear that this Haberden, Bouchard node, you know that BP in HD quality. So that will become the osteoarthritis. Along with that, you can see that the marginal osteophytes. We have seen that in the osteophytes would be there in the X-ray. We have seen that the subchondral sclerosis would be there. Joint spaces are constricted. We know that there is a loss of the cartilage, degeneration of the cartilage, due to which the joint space will be constricted. Okay, so I hope this is clear to everyone. Did you feel any difficulty? Oh, my camera is on. Sorry. So did you feel any difficulty? You can just open your microphone.